All right, ladies and gentlemen, are we in the mood to be inspired in between our hot flashes and weird cravings? Who wanted a chocolate bar for breakfast this morning? No, really, did you? Anyone? Am I the only one that wanted a Snickers? I've done it before, just letting you know. Though I did tell my children that was very, very, very irresponsible and not nutritional, even though there is a little bit of milk and chocolate, but you know. And the peanuts too, that's some protein. Okay, maybe it wasn't the right choice. So I talked about the fans that are on your table. And gentlemen, feel free to use a fan too, because it might get a little hot under the collar for y'all here too. But I think it's really important, and we were, myself and the two doctors that we're going to be speaking with, we were talking about this. It is really important for the gentleman to be in this room as well. And we really, really do hope that at the end of this wonderful afternoon that you go home with more knowledge, but questions, because we love questions. And when you show interest in what's going on with us, that is gold. So ask us questions, because no question is stupid, but it's certainly going to be appreciated, because at least you're trying to understand. Especially when your wife needs to go, or your significant other, or your daughter, or whatnot, needs to go into the other room and just scream in a pillow for no reason, you will finally understand why. And it has absolutely nothing to do with you or the color of tie that you might be wearing today. Okay. But we're going to talk about, we're going to sort of get into the nitty-gritty of everything that we possibly can, hopefully answer as many questions as we possibly can. We have about a half an hour's time, but we are going to be as open and honest and raw as we possibly can be. And then, of course, afterwards, if you have questions, certainly do ask them. But please put your hands together for two incredible women who I've had such an honor to have some time with before I get to share them with you, and getting to know who they are, and I mean they're incredibly successful in their careers. Put your hands together for two esteemed doctors from Oakville Valley Health's Markham and Stouffville Hospital, obstetrician and gynecologist Dr. Gita Singh, and family physician Dr. Amanda West. Thank you both so much for doing this. I kind of feel like this is like this, I'm having my own private doctor session, but I just brought all my best friends with me. So thank you for that. But let's sort of jump right into it. So many questions when you hear the word menopause and perimenopause and the thing, the change. Why do they call it the change? Anyway, that's another question. But Dr. Amanda, let me ask you if you can kind of dive into sort of, you know, our definition, if you will, of what menopause is.
Yeah. So menopause is when we haven't had a cycle or a period or a menses, whatever you want to call it, for 12 months. Unfortunately, it is not something that we can pick up necessarily on lab work, so people come in wanting their hormones tested. It really is a clinical diagnosis when we've had 12 months of no period. Preceding menopause, though, is perimenopause, and that's very different from many people and can last for anywhere from 5 to 10 years. And this is where it feels like your hormones are going up and down, because they literally are going up and down and up and down. So that's what the perimenopause time is.
And Dr. Singh, there's a lot of symptoms, and it's not the same for everybody. So I want that everyone to realize that if you haven't gone there yet, or you're already there, or it's not, you're not going to sit next to your girlfriend and go, oh my God, you're having the same. No, it's not the same for everyone. So talk to us about, I guess, the long list, can I say, of symptoms?
It's a very long grocery list. And each person, each woman will have her own individual fingerprint of what her symptoms will present like. And I think one of the most interesting points to make is a lot of the studies that have been done on menopause have only included sort of a very dominant ethnic group. And so a lot of people have very different symptoms outside of that they may not even discuss or associate with menopause. So when we first think about menopausal symptoms, I think we think of an older woman who's already past menopause. But as I saw somebody earlier this week who was just 40, I realized that many physicians may not even think that her symptoms are real because of just how young she is. So firstly, we think of things along the lines of hot flashes, sweats, those vasomotor symptoms that physicians talk about all the time. And even those can present very differently amongst different groups. So for me, when I first weaned from pumping, it felt like an atypical sunburn. And I don't think many people have described it like that in the literature. So I think a lot of times that those kinds of things can get missed. So we have vasomotor symptoms, we have mood symptoms that can run the gamut from depression, anxiety, anger,
Irritability.
rage, irritability. And then we have musculoskeletal system symptoms of joint pain, fatigue, hair and skin, and the urinary tract, the genital tract.
So if I go back, I started getting mine when I was in my 40s, and one of my indications when I started paying attention to it was my husband and I, we went away with the kids. We went away on holiday. I have 3 children. After I had my third, God bless my husband, I said, I love you, and we're done. And he said, really? I went, no, we're so done. I can't, unless you can give me a child that I will have no horrible symptoms from, we're done. And while we were on holiday, I was late. You're like, all right, it's been busy at work. I was not just late, I was late. And I thought, oh my God, we're gonna have a 4th child. And I was preparing. And then on the last day of vacation, it came with a vengeance, and I was like, what the heck was that? And then I started to track things and noticed. So I guess the question is you would go to your family doctor, but you also need to go to your gynecologist and your obstetrician. So can you kind of walk us through sort of that, I guess that journey in terms of as you're trying to figure things out, getting that assistance?
Yeah, so as a family physician, we are a wonderful place to start because the symptoms are so varied. There isn't necessarily a test, and we want to make sure that we are indeed dealing with perimenopause or menopause, and they're not missing anything else as well. So I'm very lucky in that I've been in practice for over 10 years, and I'm, brought my patients through all of their childbirth, and now we're all kind of going into the perimenopause stage because your practice tends to mimic you. So here we are. It's wonderful when they come in, and sometimes they're coming in because they're concerned about perimenopause, and sometimes they're coming in because they're concerned about their mental health. Maybe they're finding their interactions are different, and so starting to try to figure out what's going on. And then, yes, depending on whether it's something that I feel I can help with, or the family physician that they're seeing is able to help with, or does it require more? Does it require a referral to the gynecologist? And we're lucky to have great ones.
So kind of give me then, Dr. Singh, that journey, because again, going to my family doctor, going to my gynecologist, you have different questions.
Absolutely, and things have changed quite a bit over the last 15 years here in Markham when I first started. So initially, people would get referred to a gynecologist when they had abnormal cycles, abnormal bleeding, and you would hear stories of women leaving an event, the grocery store, wherever, because they had flooded through their cream pants in a restaurant or whatnot. Those are the stories you would hear initially. And as I mentioned, I had a patient that I've known for many years through her pregnancy and a couple of surgeries, and then recently came to me in the last year saying that she's raging and surprised that she hasn't had a divorce already. And so I think that those sort of symptoms and women coming forward and being more comfortable talking about it is starting to happen earlier, in some cases in late 30s or even early 40s, where people are starting to pick up on those subtle symptoms because of self-awareness. So for sure, the initial journey starts with the family doctor, but I think we have to acknowledge in this province that 2 million people don't have a family doctor, and sometimes they'll go to a walk-in clinic or they'll try and find other means of getting a referral to specialist care through friends of friends or networking.
One thing, if you guys could also just address as well when we're looking at other resources and other means. I mean, we've all done it. You've all gone on WebMD, or you've looked up and say, "Oh, why are my feet hurting? What's this? What could be the cause of this?" So, can you both just touch on that briefly in terms of the guidance for that? Because I can put anything online, and I'm not a medical professional.
Yeah, so I think if we're looking, everything has its pluses and minuses. The wonderful thing of social media is I think more and more women are aware of perimenopause. It's being discussed, and menopause, the symptoms, which is wonderful. I think the downside to the WebMDs, the Instagram, the TikTok, is that the information isn't always correct, or people are blaming things that are not perimenopause on perimenopause. It must be because of this. I'm having night sweats because of this, but they're in their 20s. And so that's actually might be something very dangerous or worrisome. So I think it's always important when able, and again, to Dr. Singh's point, there's not enough family doctors. We are having issues with that, obviously, to speak to someone with an expertise.
Exactly. Treatment. I think that's sort of one of the big things. What can we do to sort of help ourselves through it? HRT, or hormone replacement therapy, is one that is commonly a lot of people talk about. But there's a lot of angles to it. Not everybody is a candidate. Openly, I'm not a candidate for it. I couldn't do it. And then I know that is there a question with regards to HRT and breast cancer patients? So maybe Dr. Singh, if you can start with that and touch on that, and sort of maybe start with what HRT is for some who may not know sort of the ins and outs of it, to sort of some more of the detailed.
So HRT is basically hormone therapy, trying to mimic either the natural hormones or indeed natural hormones. There are some categories even within the pharmaceutical industry that are more natural. And then there are bioidentical hormones as well, and we can speak to that later. But generally speaking, hormone replacement therapy was designed to basically alleviate symptoms that occur in perimenopause and menopause, and treat those symptoms to the best ability that they can, and dosing accordingly.
What kind of advice? Like, who should say, if you've got a patient that comes to you and says, I want to try HRT, how do they know if they're a candidate? How do they know whether or not that's the journey that they should be going down? Are there other alternatives?
Yeah, so usually the first place to start is on the history. What are the symptoms that they're experiencing? What symptoms do they find distressing? Because some people will find, I have a hot flash here and there, but as long as I wear layers, I'm fine with that. Versus the person who is finding that it's really interrupting their lives, it's happening very frequently, they're finding they need to have changes of clothes. So you need to figure out what are the symptoms. Some of our symptoms are based on the fact that we're low in our estrogen, some are progesterone-based symptoms, and that can help us also guide our treatment. Obviously, your past medical history is going to be very important. There are certain past medical histories where it is not appropriate to do hormone replacement therapy. And then some people are more open or looking for medications, others aren't. I like to call it a ladder. So we start at the bottom rung, we look at lifestyle. So diet, could we go Mediterranean diet, more plant-based diet? Exercise, are we getting enough exercise? As we start to have less progesterone and estrogen, that affects our bones. So are you doing weight-based training? That becomes really, really big. And then, move up the next level. Are there some supplements? Are we making sure we have enough vitamin D? And then up towards the hormone replacements.
Can we dive into the breast cancer question as well? Is it something, I think there is a concern that HRT can cause breast cancer. Are breast cancer patients candidates for it, not candidates for it? And if they're not, what's the alternative for them?
That's a great question, because there's so much misperception about it out there. So in the early 2000s, there was a huge landmark trial called the Women's Health Initiative that came out. And what people don't realize is that study was actually designed for determining whether hormone replacement therapy could actually be beneficial to prevent cardiovascular disease. That was the initial design of the study. It wasn't meant for women with menopausal symptoms or who were very symptomatic. And it found that no, it doesn't protect the way they had hoped it would protect against cardiovascular disease. And one of the things it picked up on is in one of the arms of the study that had both estrogen and progesterone was that there may be a slight increase. And when we say increase, we're talking about 6 cases in 10,000 women. So it's not a huge number. And unfortunately, that's what sort of caught hold in the media and in sort of the general population, with people trying to pull women off of, or women just being scared and coming off their hormone replacement therapy and not realizing that the actual risk, the absolute risk, was very low. Since that time, we've looked at many different studies, and the risk of being on hormone replacement therapy for less than 5 years, that relative risk of increasing your personal risk of breast cancer, is not much higher than being obese in postmenopause or being a regular alcohol drinker, and that other risks that we don't think of as severe are actually much worse. So breast density is actually the greatest individual relative risk for breast cancer at 6.6. So that's 6.5 times baseline risk.
What are the, what's the alternative to HRT, would you say, Dr. West?
So, I mean, beyond the lifestyle, the supplements, there is, and actually Dr. Singh can probably speak to, there are a few pharmaceuticals now that do not have hormones in them for those patients.
And so to continue answering that as well, can we talk about timeline as well? How long, if you are taking HRT, how long you should be on it, weeding yourself off of it? What are you finding?
So there are a couple of things, as I'm seeing sort of the flash for the time. We could talk about this for quite some time. A couple of things. The basic general rule is to keep somebody on the lowest dose possible for the shortest duration that deals with the most of their symptoms. That's the guiding principle for all physicians. So generally speaking, most people will not need HRT for more than 10 years, but less than 5 years actually. Some people will need it for 5 to 10 years, and some people will need it for their entire lifetime to maintain their symptom control. Mm-hmm. In terms of breast cancer patients, as Dr. West mentioned, there are medications that have been around for a long time. One of them is relatively effective and is non-hormonal, and we've used that successfully with 25 to 30% improvement in symptoms. And there are some wonderful medications. One has just been approved by Health Canada that is a non-hormonal medication that works on specific receptors in the brain for vasomotor symptoms, which is very exciting. And one is seeking approval and will probably get it this year. So there's a lot in the pipeline for breast cancer survivors because we know breast cancer is also on the rise.
Exactly. That's amazing. That's actually very, it gives you some hope there as well because, you know, in terms of what the alternatives are. So we've kind of talked about, sort of got a sense of sort of where things are at, what kinds of things we will and are going through. What options there are, but the discussion about menopause and perimenopause is still, and I'm going to use the word, I still think it's still very much taboo. How can we shift the conversation so that if I need to take a personal day at work, it's understood. I don't have to defend why when I wake up in the morning, there my mic's back. When I wake up in the morning, my feet hurt so much that I'm not able to walk very well, for example. Or I've heard, you know, someone's joints are just, you're exhausted. How do we bridge that, have that conversation in the workplace?
So I think it starts at home, right? Starting to talk to our family members, our daughters. We spend a lot of time preparing our daughters for their first period. How much time do you spend preparing for perimenopause, menopause? So speaking to our mothers, our aunts, whoever, And to your point earlier about it's important that there are some men in the room, speaking to our fathers, our sons, so that they're aware. They're in the workplace with women, so they can understand they're living with you. Why are you just so irritable today? Well, it's because I don't know. Right? So by starting in the home, making it normalized, hopefully that will start to spread, speaking to our friends, our male friends, and then just being honest in the workplace. You know, why do we have to hide it? You wouldn't hide if you had gastro. So like, why do we have to hide this?
What are you finding? Like, is it just in your experience? Are you finding that there's more openness about it?
I think it's the next frontier.
Okay.
I think we have started to have a conversation. Maybe it's my algorithm on my phone, but I do seem to be getting a lot of menopause articles sent my way in my Apple feed. I do think it's having a moment, but I think there's a lot of work to be done. So I think, 20, 30 years ago, we made a lot of efforts in terms of equality and understanding pregnancy and being a mother in the workplace. And I see this as just being an extension of that. So I know that, we're a little bit short on time, but we could talk about this forever. About 15% of the workforce may be compromised, of the female workforce, in that perimenopause, menopausal time, just because there's no accommodation for the things that are required, like hybrid working or taking time off or coverage for the expensive medications for hormone replacement therapy or non-hormonal replacement therapy, these medications that are just coming out that are going to be a lot more expensive to cover the research and development component.
I want to end on and get both your perspectives on this. For, I guess, when we look at the next generation, and I'm talking about the next generation of girls, but also the next generation of, just the next generation overall. Having that switch in perspective, how critical is that, so that when we're having events like this, the conversation is quite different, and it's more sort of that informative of, oh, I noticed this symptom or da-da-da, versus us breaking down the barriers. How critical is it for the barrier just to not be there anymore? And when someone says, yeah, I'm having some menopausal symptoms, very similar to say, yeah, I need some time, I'm having a migraine, right? No one hides a migraine. Like you said, no one's gonna hide if you've got the flu or a cold, but we are very, very quiet still when it comes to dealing with these symptoms. We're very quiet when it even comes to our period. I was afraid to tell my boss when I was pregnant for the second time. I've lost track of how many kids I have. But I was, but it shouldn't be that way. So how important is that as you're dealing with older patients, but the younger patients as well, and having those conversations and making it normal?
I mean, it's so important. One of my jobs is training the future family medicine physicians. We have a residency program. And so teaching them to just naturally put it as part of our periodic health exam. Are you experiencing any of these symptoms? Do you have pain with intercourse? Do you have, just making it very normal and normalizing it, so that women feel more comfortable speaking to their physician, bringing it up. And then in the workplace, similarly, you made the comment, or one of you made the comment about childbirth and pregnancy and being more accepting, and so this is the next level.
Yeah, I think on that note, it's sort of in line with what they're teaching at my daughter's school, right, about mental health, name it to tame it. And I think the first step is naming it. We really haven't done a very good job about just being comfortable. I gave a talk earlier in the year about perimenopause and menopause, and some of the physicians who came up and were asking about it afterwards were just looking to see how do we even bring this up in certain communities or neighborhoods where there's a dominant ethnic group which wouldn't even know how to discuss this. And I think part of it is just looking in your village, in your group, in your community, how can you be an advocate for exactly what Dr. West was talking about, which is just discussing it openly without any stigma, without any judgment, and just normalizing it that way, just being a leader on some level to sort of make it normal. and to name it in order to tame it.
And I think you also hit the nail on the head when you talk about sort of the cultural side of it as well. In certain communities, it isn't talked about, and women and females are referred to or are seen differently, especially when they're on their period, when they're pregnant, when they go through, perimenopause and menopause. So maybe it starts with kind of that generation that we have nurturing in our homes and getting them to help us break down those barriers. You both are amazing. Thank you both so very much. Dr. Gita Singh, Dr. Amanda West.